Thanks very much, Sarah. And then the final presentation we have now is from Gerrard, who's from the Public Health team at Kent County Council.
Thanks very much. So, good afternoon, ladies and gentlemen, and thanks very much to Tom and Geisha for the invite to Kent County Council to allow us to present our work. So I'm coming at this very much from a public health analyst perspective, so please excuse me if the three case studies I present have a strong public health bent to them, although I think the principles that underpin the linkage work that we've done apply to the other case studies that we've had an opportunity to listen to. Oops. So this was what I was asked to do, to talk about what we've done in terms of assembling our data repository, to say a little bit about the work that we've been doing and the aims and objectives of that, the underlying challenges that were encountered, the critical success factors and the benefits to the council and residents as a result of the work that we've been taking forward. So an overview of our work on linked data. We call it the Kent Integrated Data Set, or KID for short, and that encompasses a time span of data reaching back to April 2014. It's all person-level data which has been pseudonymized using NHS number on landing within the Kent Integrated Data Set. So that's actually a key success factor in all of this, that we've been able to stitch these data sets together from health, social care, GP practices, district councils is data that's coming. But the common denominator in all of that is the application and linkage using NHS number, which is then pseudonymized so we can maintain patient confidentiality. The provider coverage at the moment straddles the acute sector, so hospitals, accidents and emergency departments, outpatient departments, community care units, primary care, that's absolutely fundamental to the work of public health, mental health trusts, adult social care, out-of-hours providers, and we're just about getting hospice data flowing into the data set as well. The ambition is to also get district council data flowing as well, again, all at person level and stitched together using the pseudonymized NHS number of the individual. But we're still working with our 7 district councils to orchestrate the process for receiving that data. The frequency of our updates are monthly. We reckon that the financial coverage is around 57% of the £2.3 billion pounds per year for the care economy in Kent. And therefore we feel that this represents a very potentially high value for money component in terms of the depths of insight and intelligence that we can glean from the integrated data set. The reporting lag typically is 1 to 2 months, so we have a 4 to 6 week lag between real time and now. But I think for practical purposes, that's completely acceptable in terms of predictive analytics and work on strategic needs assessments. On average, we reckon we've got between a 1 to 2% non-linkage rate. So these are problems encountered with individuals who, for one or other reason, we're not able to attribute an NHS number to and therefore can't pseudonymise it, and they have to be excluded from the linkage process and attribution to the KID. But I think that's pretty good going and gives us an indication, especially with our health data sets, of the quality of data that we're dealing with. That's not exactly the case with our social care data sets, but I'll come on to that a little later on. So, and we also aren't able to identify individuals and the houses that they live in, although that's something that we're interested in doing in the not too distant future. Oops, I keep on going the wrong way. So I'm not sure whether you can see that. I hope you can. I'm not sure whether the slides have been made available. If you can't see it properly, you can look at it later on. So the flow of data, I won't go through all of this, but we're getting GP practice data, as I said, mental health data, a subset of each of those very expansive data sets. First of all, we enter a dialogue with the data providers. We agree the subset of data that will flow into the KID. Typically, that encompasses the key demographic information that we need for analysis, coding data on care interventions. So, for example, in primary care, the READ coding; in secondary care, ICD coding or procedural coding; in social care, the types of packages that are delivered in terms of social care delivery models. And those subsets then are flowed into our data, third-party data repository, linked together, and then we have, as it were, third-party secure access to that linked data set for the myriad types of analyses that we're interested in doing. So, indicative gaps. This is just an example from one of the 7 CCGs that we have straddling the Kent economy. Just to give you a sort of a feel for the type of cost containment that we can draw within the KID, the type of amounts of money that we're able to peruse from an analytic perspective. So in terms of acute service, we reckon we're capturing around 30% of the costs. Community services around 39% in terms of the gap. Mental health 63%, and primary care 70%. Continuing healthcare is perhaps the sort of the worst of all in terms of our ability to gain structured costs from those data sets. But again, from a data quality perspective, these are very important feedback paths to our data providers to up their game, as it were, when it comes to the quality of the data they provide. From a public health perspective, one of the absolutely fundamentally important data sets that we're interested in, because it's longitudinal, it captures the majority of the kind of healthcare interventions that people in this country experience, and that, of course, is our interaction with general practitioners, the events that we experience as we sit along this, the GP interface, or the home visits, or the telephone contact. And this is just a slide just showing the distribution of participating practices that are now flowing data into the Kent integrated data set. So of the 200 practices across, 200 GP practices across the Kent economy, we're getting, that number's changed now, we're getting now around 75%. So 3/4 of our practices are actively flowing virtually their entire minimum data set for us to be able to look at it in a pseudonymized way. So the challenges and success factors, well, I just sort of thought about these anecdotally from my own experience, having sort of travelled the journey with all of this. And the enduring presence of a respected local champion, in this case in our public health team, that's Dr. Abraham George. He's the strategic consultant lead and in many respects the architect of the way the KID has developed. And it's really been down to his presence, his communication with our needed providers that has facilitated the advent of the KID. I think the other thing is the serendipitous, I could say, presence of an extremely experienced data security expert that Kent County Council happens to have. That chap's name is Alan Day. I know this has been filmed, so Alan, your name has been mentioned. This guy can read legal documents and assimilate legal information like no other person on the planet can. And his advice and expertise has really helped to smooth the way with our data providers, both in terms of providing solid legal-based assurances, but also helping us as a public health team to overcome the legal impediments and obstacles to assembling the KID. I think the other thing, of course I would say this because I lead the health intelligence function for the council. We are blessed, I could say, with a team of 14 very capable analysts with good quantitative backgrounds, mathematicians, statisticians, epidemiologists, social scientists, and a chemist as well. So, and I'm not saying that to be presumptuous in any way, but I really do think that one of the success factors has been to have the technical resource to marshal the utility of these data and to demonstrate that in a sound and robust way to our data providers. Third, the establishment of a clear and well thought through data quality system. We invested at a Kent senior grade, the recruitment of a data quality specialist who has, that's Tom Bourne, some of whose slides I've borrowed for this presentation, who has really systematised our ability to think about data quality and also to think about the precise channels through which we can feed those data quality issues back to our data providers. That's an absolute success factor as far as I'm concerned. And then finally, the availability of a trusted third-party data warehouse team. We work with the Kent and Medway Health Informatics Service. This is a third-party warehouse, which is the conduit for all of the data flows. And these have expert skills in data manipulation, programming, and of course, data linkage. So, final few slides now. The kind of context within which we hope that the benefits that this linked data set will arise is Kent's a big population, 1.5 million people, a major care economy, as I've already said, around 2.3 billion straddling health and social care. And we reckon we're capturing around 57% of that care economy at the moment, and it's expanding all the time. We have, again, from a public health perspective, major cost pressures affecting our economy. I don't need to say that to you, but depending on which estimates you look at, around 30 billion in terms of a black hole in the care economy, healthcare economy in particular, and a strong public policy push for more evidence on integrated care models that can alleviate some of those pressures. We reckon the £30 billion hole translates to around £830 million for healthcare in Kent alone. In addition to that, and something that we're very focused on in public health terms, the rising tide of people with chronic conditions and multiple morbidities. So these are people who are typically post their 40s, have a mild form of, let's say, hypertension, but also may have diabetes, perhaps a little bit of dementia. They're multimorbid, and they generate a lot of cost in the system. Ellen Nolte of the European Health Observatory reckoned that care for chronic conditions accounts for around 55% of all GP appointments, 68% of outpatient and A&E appointments, and around 3/4 of inpatient bed days. That's data for England. Furthermore, 70% of total health expenditure associated with the treatment of around 30% of healthcare recipients that have one or more chronic conditions. Something that we are definitely focused on in Kent and from public health perspective focused on elsewhere. This is case study number 1. Using the linked data set, we've been able to assemble a risk load algorithm for every practice in Kent. So this is the predictive risk of an individual being unnecessarily or probabilistically unnecessarily admitted within 1 year of the assembly of the risk score. The risk score has we've only been able to construct the risk score because we have good linked data. It's based on factors such as the extent of polypharmacy of the individual, their readmission history in previous 3-year period, their age, their sex, and other characteristics. So we've been able to model that data, and what I'm showing you here is a logistic model that has adjusted the scores for the ethnicity of the practice, its deprivation load, whether it's rural or urban, and the differential age structure of the practice. So what you can see here, even after adjustment, is a very interesting distribution with the risk of being admitted at the good end, at this end, and an elevated risk of being unnecessarily admitted for a long-term condition at the right hand of the graph. And we've been able to use these data to enter from a council perspective into meaningful dialogue with our general practice population, not to be accusatory in any way or pointing fingers at them, but simply to enter into a public health dialogue about the management of people with long-term conditions. Case study number 2, this is just an extract. These again are practices in the east of our county. And what we've been able to do here is to stitch on the community, adult social care, accident and emergency and non-elective care costs of every individual in the practice, cumulatively for 30 months, convert that into a per capita cost for each individual practice, and then the data have been statistically adjusted for the deprivation load for the practice. So we remove the confounding factor of deprivation. I think we're then looking essentially at the kind of naked, unwarranted variation. And once again, that distribution may be acceptable, but I think it's unwarranted. I think it's indicative of people bouncing around the system, probably at the comorbid, very comorbid end of the care spectrum. And once again, I think it presents potentially enormous cost savings if we can engage senior management to think about rejigging the way we provide care for people with complex care needs. Is that cut? It's right, it's just 2 more slides, I think. We've done a matched case control study with the Kent Fire and Rescue Service. So we looked at people who'd had a home visit, linked them using pseudonymised NHS number with the utilisation of accidents and emergency service, and then compared that with a control group to see whether the home visit intervention had a tangential and unintended impact on reduction of utilisation of accidents and emergency service. I won't tell you what the outcome was, but you can read the results on our website. I'll skip over that. So thanks very much.